Hi, morning, folks. Morning, afternoon, morning, evening. Thank you all for being here, being in front of your monitors for another installment of this exciting mini-series from Columbia University, courtesy of the MVP network. Today, we're going to be discussing health, healthy life and equitability, the public health aspects of sustainable development, and really happy to welcome for the Global Classroom lecture Dr. Sonia Sachs, who's at Columbia University. She is the director of the health programs at the Earth Institute, a pediatrician by training, and I can vouch from personal experience with my daughter, most excellent pediatrician. And then the pediatric world lost a fine pediatrician, but the public health world gained a fabulous public health practitioner. And so we're really lucky to have her here. She's been involved for many years in a range of public health issues with a heavy focus on Africa. And today she'll be kind of walking us through not just the SDG for health, but also some of the interlinkages and from kind of, I think, from a very practical experience. So I'd like to welcome Dr. Sachs. And for those of you who know them, her lesser half is Professor Jeff Sachs.
Thank you, Chef.
Let us speak for a while, and then we bring up the presentation. Great.
You do that. I love checking on Shiv's daughters, who are now grown and incredibly high achieving, because when I hear how well they're doing, I keep saying to myself, boy, was I a good pediatrician. Yeah, so I am very grateful for Shiv and Glenn and the leadership of this course to invite me to talk to you about health and equity, because in fact, I do want to imbue you with the incredible excitement that I have for the process that you all have been studying and following, which is the SDG process, because actually it comes at the end of a pretty horrific roadmap of health in international health for the last 70 years. So I'm really thrilled, actually, that I think finally we have the right approach. Obviously, nothing is solved, but we have now a construct that I think is the right approach, which is why I would like to walk you a little bit through what has happened, and that it took us pretty much 70 years to get to a point where it's still 0.0, but it's a point at which I think the approach is right, and I think will succeed. Could I ask you for, oh, maybe I should be able to do this? Thank you. Thanks. Thank you. So what is the 0.0? Here we are. It's at this point, 2015, and we still have this unacceptable vista, which is that 1 billion people live and die in poverty, 6 million of children under the age of 5 die of absolutely preventable and treatable causes, as well as 500,000 of women dying related to pregnancy. And then, to me, this just a quick image of unacceptably huge difference in life expectancy between some people in some parts of the world and people in other parts of the world, which, by the way, just proves the point that a life expectancy of now close to 80 in some parts of the world is achievable, and therefore the situation for the other people whose life expectancy is much lower is really an aberration. And that's important to know, that what we're after is something that we know is possible, and it's just not available to some parts of the population. Just to remind us all of something we all know, because you study it, I study it, that health is a broader concept which cannot be looked at in vacuum. Health obviously depends on the ecology, where you live, what are the circumstances. Road transportation is critical when you're in an emergency, water, sanitation, gender equity, education, poverty, hunger, and of course, healthcare delivery system. But this is just to remind us all that it's not a simple one intervention challenge. But this is why I'd like to just quickly walk you through what's been happening in health for the last 70 years, and why, therefore, you who have not lived through the frustrations of these failures, why, therefore, the SDGs are so exciting for those of us who've been frustrated for many decades, actually. So to remind you, in 1948, the Universal Declaration of Human Rights by the UN should have been the start of the revolution in facing the health circumstances, but it turned out to have been just that, a statement, and it did focus on mother and child correctly. At the same year, the WHO actually, right in its constitution, said that health is a human right, and that it should be equitably distributed without distinction, race, religion, political belief, or economic situation. But again, it turned out to have been just that. What should have been a beginning of an approach was just a beginning of a statement. And then famously, in 1978, many of you may have read or heard about the Alma-Ata Declaration, which was sort of the universal health coverage equivalent in the 78, called Health for All, meaning that by 2000, i.e. 15 years ago, we should have achieved universal health coverage, which is actually where we are now at the baseline for. And so Alma-Ata declared primary health care, social equity, importantly, and that it was a state responsibility, which was a major step up. But again, it turned out to have been just a commitment, but not fulfilled. And they were, now in retrospect, these wonderful, by the way, assessments and proclamations failed by not stating anything about how do you get there, and what would be the funding mechanisms. So then, infamously, the last 20 years of the last century were the so-called structural adjustment era, where the IMF and the World Bank decreed and held countries down to the fact that health and education is a free market commodity, and therefore should not be subsidized or invested to by the public sector. And so in health, they were insisting on cost recovery. And of course, all we saw as a result was horrendous raging epidemics that you all know well about: AIDS, TB, malaria, and really a very serious health situation in sub-Saharan Africa. Then there was a breakthrough, and actually it's really a good learning lesson, again, leading up to why I think the SDGs are really unique opportunity for us. This was a real breakthrough. People refer to it as the revolutionary intervention in child survival and development by a famous UNICEF leader named Jim Grant, about whom there's a book right now, which you may want to read. He was really inspirational. And he he designed and implemented and succeeded in what's called vertical programs at scale. He took 4 things: growth monitoring of children under 5. He emphasized exclusive breastfeeding and exclusive breastfeeding till 6 months and continued breastfeeding till 2 years, universal immunization, and oral rehydration solutions for diarrhea. And this vertical program, vertical meaning that it didn't go through the health system, it was just a massive, once or twice a year, massive assembling of volunteers, Red Cross workers, to distribute kind of a campaign-style interventions. And it was hugely successful. Immunizations of measles have been measured to go up from 20% before he started this to 80%. Huge success. And the child mortality dropped by 30%. So this one-off, once or twice a year campaign style vertical program really worked. And it did not require any system because you just amass once or twice a year, UNICEF, WHO, Red Cross, all amass a huge workforce and implement it. So it's inexpensive, easily scaled, and doesn't require any other systems. But unfortunately, what happened then, obviously, is that it had that impact, which was life-saving for thousands or millions, but it had a limited impact. In other words, it didn't continue. The deceleration in child mortality did not continue. So because of that, in 1992, the WHO and UNICEF decided, okay, so outreach, using community health workers and volunteers to massively distribute immunizations, etc., is not the total question. Let's also focus on the clinics and retrain the clinicians, the nurses, in what's called integrated maternal child, IMCI. And that focus on clinics. And unfortunately, the idea was actually very good. The integrated medical care of illness, all of a sudden I'm blanking on the, and it did actually have a very interesting approach, which is that it taught the nurses what's called syndromic diagnosis. So in other words, you didn't have to be a particularly highly trained technician to be able to at least work on being able to diagnose and treat correctly the main killers of children: diarrhea, pneumonia, malaria, measles, malnutrition. And it was done by a syndromic approach, meaning if a child appeared with fever and diarrhea, they probably have this. If it's fever plus respiratory distress, they probably have that. So it's not a particularly medical or clinical differential diagnosis. It's really just a simple but effective way of upgrading the personnel in the clinics to diagnose and treat properly. Unfortunately, this was, when it was evaluated by the WHO for 10 years, starting 1997, it turns out that outputs improved. There were many more better educated nurses in the clinics, but it had no impact. Child mortality did not decrease. And it's because it was based on the wrong assumption, unfortunately, which is that if you improve the quality of care, that people will come and that it'll have an impact. So it didn't address, so it basically didn't affect the poor people who were nowhere near a clinic, didn't have a way to get to the clinic, didn't have a way to pay for the clinic visit. So there were still the financial barriers, physical barriers, social barriers. And of course, it didn't address the systems approach at all. It just focused on what happens in the clinic. But this is what happens, both the pioneering intervention by Jim Grant, as well as this integrated management of childhood illnesses, were attempts, valiant attempts that we all applauded, that were good solutions, given the fact that the international community was given, we were all given the wrong premise, which is, the premise was, if we, the donors, give you X amount of dollars, we give you $1 per person per year for Nigeria, what will you do? So under those circumstances, when the premise is, this is how much money we have, what is the most critical thing to do, then you come up with these kinds of solutions, which turned out to be very partial and imperfect. I just want to quickly show you this graph because it explains a little bit the choice of the MDGs, why they focused on what they focused on, at least in health. This graph, for those of you who've studied the DALYs, the disability adjusted life years, the DALYs are on the horizontal, and the different regions of the world are on the vertical, and there are three groupings. Oh, I can actually, you said I can. Yeah. three groupings of diseases. This is the burden of disease. The top one is high income, and this one is Africa, and these are the other regions. If you look at the three different shades, you notice that the light shade at the top tip of each bar, the light shade is the so-called category 3, and that's deaths and disability due to injuries. And although there is a difference between high income, which has the lowest, and let's say Africa, which has the highest, otherwise they're pretty similar. Same thing with the second color, which is the group 2 diseases, category 2 diseases, the middle blue, which consists of non-communicable diseases. Those are deaths and disability due to heart attacks, stroke, lung disease, mental disease, depression, etc. And again, high income as well as Africa, as well as the other regions, this middle part of the graph, the light blue, is pretty similar. What is disproportionately different is the dark blue. The dark blue is the so-called category 1 diseases, and that's a group of just three subgroups. That's infectious diseases, maternal and perinatal problems, and nutritional conditions. So it's just in this group that you have the malnutrition, the deaths of newborns and mothers, and then the infectious diseases like TB, HIV, malaria, diarrhea, pneumonia, measles, the other parasitic diseases, and all of the immunization preventable diseases. So the realization was made that the disease burden is hugely, orders of magnitude bigger in Africa, let's say, sub-Saharan Africa, than in high-income countries, huge disproportionate difference, but it's in a very restricted, relatively small group of disorders. And so number one, it made people realize that if you focus on these disorders, you may have a more impact. And number two, the fact that these disorders, these category 1 disorders, are no longer an issue for high-income countries shows you, by definition, that those are addressable under different circumstances. So it's not some sort of a enigmatic, problematic disease. They're easily addressed in other parts of the world. So it was with that in mind that a couple of things happened in the year 2000, and I would say the things that happened in the year 2000, the first decade, really were real acceleration of the proper approach to equitable health care delivery, and led up to the SDGs. One of the main path-breaking points was the Commission on Macroeconomics and Health under Gro Brundtland, who was the head of the WHO, really an inspirational figure, who convened a group of public health and economists and ministers of health and ministers of finance to deliberate on what could be done on the approach to health. And they made what to us public health people was also kind of a breakthrough statement, which is that health, and therefore focusing on good health, is actually a precondition to economic development, which, believe it or not, was not at all the way people thought about it until then. Health was hugely underfinanced, health interventions, both inside countries. The ministries of health had and still continue to have way too little parts of the budget, and international donors also didn't focus on health because the idea was the country is so poor, let's not right now focus on what they cannot deliver until the economic development, until the country is better off enough to address the health issues. And so this commission really turned it upside down, saying, no, focus on health, invest in health, and development will, obviously the productivity of the people, et cetera, will lead to better chance for economic development. And so what that did is to get the ministers of finance engaged, and much more funding became available in the form of, down here, well, Gates hugely invested in health, and then the multilateral funding mechanisms like the vaccine ones, like the AIDS, TB, and malaria one, the HIV one, PEPFAR. So the Commission on Macroeconomics and Health really had a major impact by putting money into infused money into what otherwise was rhetoric. And they noticed the disproportionate disease burden by the category 1 that I showed you, the infectious diseases, delivery-related problems, and malnutrition. And they costed it out back in 2004. No, I'm sorry, back in 2000, the approximate public health subgroup within the CMH costed it out to be about $34 per person per year. It has now, since then, 15 years later, and some added interventions later, the WHO now thinks that it's about $80 per person. But that relatively small amount of money, $80 per person per year, would now hugely improve the child and maternal mortality. The other thing that happened, of course, is the MDGs, which with all of its flaws was, I think, also transformational. It was the first time that the international community actually agreed on certain priorities. And, you know, it really was the first time, and the only second time is SDGs in a much better, more expanded role. But the MDGs was a preamble to it because it was the first time that the international community, and specifically at the UN, really signed on to certain priorities. And then for me as a pediatrician, the critical part was also the Lancet series, which actually Lancet for 10 years, one after the other, just put out these unbelievably impactful, clear dictates on what it takes to have a child be well nourished, what it takes to have a mother deliver a healthy newborn. It really gave us the Bible for clinicians. So we really did have a really good compendium of what to do to address the major killers, especially in low-income setting. And then just to go back to the multilateral funding mechanisms, those were actually important, and they were also new in the year 2000, because until then, foreign aid was given, and still is, sporadically, usually based on political priorities of the donor, and usually almost never based on what the actual need was, but just by how much they happened to have and how much they wanted to give. Whereas Global Fund, which and Gavi really are exceptionally new funding mechanism in that it's multilateral, so it's not US giving to Nigeria, it's multilateral, pooled, and countries come to these funding organizations with the expectation that their programs will be judged on technical merit and on feasibility of implementation, rather than who likes whom and, you know, what president wants to curry favors with another. So the pooling of the funding was very important and impactful. And this slide just shows how, in fact, starting in the year 2000, there was a huge increase in foreign aid. And a best example that if foreign aid is used properly, it actually does save lives. And so you see that most of the traditional donors increased their investment, like the bilateral development agencies on the bottom, the red ones. But mainly there's this huge increase in the Global Fund, Gavi, component of the foreign aid. And so this really hugely changed the situation by finally putting money into the system. And then we all are aware of the fact that there was therefore a complementary subsequent decrease in malaria deaths all over the world, but especially notable in Africa, which is the purple line, because of the Global Fund, finally a huge increase in treatment rather than just bereavement aid, and AIDS-related deaths finally plateaued off and declined. So the MDGs for me were really instrumental, even though they were maligned and the US tried to ignore them as much as possible, but actually they became the organizing principle in most of the world in low-income setting. And I think the reason, again, that they were really so transformative and led up to what I think will be a much better system, which is the SDGs, is that it was based on a consensus process, and it was holistic. It addresses health as well as education, as well as infrastructure. So it's the first time that the development community looked at the problems in low-income setting in a holistic way. It took burden of disease into account. In other words, they looked at the DALYs that I showed you and picked out what are the diseases and conditions that are really disproportionately burdening the low-income countries. Let's focus on those. Of course, people also in low-income countries die of things that people in rich countries die of, but let's first close the gap, the convergence that the economists call. It was goal-based, which, believe it or not, made a huge difference, because until then, many of us had arguments with international agencies who said, well, we are giving money. Look, we gave $2 million to country X, or, you know, we gave the money, and we gave some money, and there was no metric of, well, how much is that per capita, and what does that mean, and what difference does it make? And so people just were able to take the fact that money was given, regardless of how much and for what, sort of as a feel-good thing. Whereas here, now, their goals. How does what you're giving, how does that relate to the fact that we're trying to decrease maternal mortality by 3/4? So these goals, and therefore the requirement to make a gap analysis, you know, if we want to, this is where we want to be with maternal mortality, this is where we are now, what do you need to do to get from point A to point B? And invites that kind of a process, which is critical. And there were actual metrics, targets, indicators, and deadlines. And so even though, of course, it was flawed in some ways, it actually became hugely successful in that it was an organizing principle in thinking and implementing. The downside, many people complain about many things. Mental health, people said, why didn't you mention mental health? And questioning correctly, what's a huge burden for all countries. But basically, the MDGs were not invented to address the non-communicable diseases or the injuries, not the second and third category. They were really just put out there to try to close the gap. And they did succeed to some extent in some places. As you know, the MDGs only spoke to the developing world. And my biggest complaint, although I would live and die by them, is that it did not facilitate any discussion and therefore any funding and therefore no focus on delivery systems. It just made a list. We need to decrease HIV, TB, malaria, all very important, but it didn't it didn't open up a discussion about how do you do that. And it also didn't, by the way, of course, address the financial burden. So it was actually because of that Jeff and Glenn and others, Pedro Sanchez and others, decided to start the Millennium Villages project because what we had at that point was the international commitment to do something. There was increased funding, or at least a commitment to increase funding. And we had the Lancet cookbook on how to address, I had a cookbook on what interventions you need if you want to keep mothers alive, children alive, etc. But what we didn't have was how. How do you deliver the services? And that's why we decided, that's why the Millennium Project, also headed by Jeff, compiled many public health and public and education and agriculture, infrastructure specialists in all the sectors to think about how the goals could be achieved, the how. And then the Millennium Villages project was actually to get our hands dirty on the ground, to learn by doing and also show how you can actually build, number one, systems, and number two, what it would cost and what it would look like. Before I tell you a little bit more about the Millennium Villages, I want to show you an argument for why systems is a critical component. The two interventions that I told you about, which is the vertical mass campaign style interventions, as well as a little bit of the clinic improvement, did actually lead to some improvement in the MDGs. So maternal mortality, as you know, went down, but only by a third, not the aspirational 3/4. Child mortality also went down hugely. Instead of the 14 million or so just a few years ago, it really is now only quote unquote 6 million, but that is not what we aspired to, which was 2/3. And infant mortality did not go down at all. And this is what I would like to quickly explain, because it's the best argument for me why you need systems rather than one-off vertical programs. On this graph, you have the beginning of the MDGs, which is 1990, and it goes up to just a couple of years ago. On this axis, you have the deaths per 1,000 live births. And so you see, this is the death of children under 5, which includes infants and newborns. And so you do see what I was just saying, that the child mortality decreased over the period of the MDGs substantially. But of course, we still have a ways to go, and we did not reach, in the aggregate, did not reach the MDGs, and will not by December of this year. But the remarkable part is this, which is that although the child mortality went down, the newborn part of the child mortality did not. And that's because for that to happen, you really do need a system. Just to show you, nutritionists and others talk about the first 1,000 days of child's life being the critical one, which is, it's what happens the 9 months during pregnancy. It's what happens during the first month of life and the first 2 years of life that hugely defines whether the child will survive past the age of 5 and be healthy. So that's the 1,000 days. And it turns out that although it's a very short period of time, in other words, if you get these 1,000 days right, it'll be transformative. It turns out that to get these 1,000 days right, you do need actually a whole system, which is the blue box below it. In order for all of this to go well, you actually need proper nutrition, you need proper antenatal care coverage, you need family planning so that the mother can decide whether she wants to or not to be pregnant. You need roads for emergency transportation, telephony. You need clinics, 24/7 clinics, to be actually properly equipped with basic emergency obstetric care, resuscitation material. You need actual midwives who know how to deliver, so-called skilled birth attendants. You need 2 pairs of hands, because the critical moment of this 1,000 days, it turns out the most critical moment is actually not only just the one day, not only just the first hour, but it's actually the first minute of the child's life. And that's because during that first minute, both the mother can die from hemorrhaging, from an improper delivery, especially of the placenta, and the baby, if it doesn't take that first critical breath, can die. So during that 1 minute, you can lose 2 lives, and that's relatively easily preventable, but that you need all of these basic subcomponents, up to including the supply chain, training, data, management, financing, a referral hospital in case there is a complication. So that's why this picture shows you why, these one-off vertical programs, can't deliver a healthy baby and a healthy mother, nor can just improving the clinic personnel, quality of the clinic personnel. You actually need the whole set, the whole sequence. And so that's what we, in health, of course, in the other sectors similarly, but that's why Jeff, Glenn, and others, Pedro and Cheryl Palm, started the Millennium Villages Project in 2004. And the idea is we know what to do. For instance, in health, in agriculture, it was Pedro who said, if you put X, Y, and Z nutrients in the soil, you will get much better yields. In health, the public health community, via the Lancet and others, really did tell us what we can do, but not how to deliver it. So it's translating science, knowledge that lives at universities, to operational, implementational knowledge. So translate science into implementation, and to learn how to design complex system, and learn how to do it, and hope to innovate on the ground as doing it. This is the health system. It's busy, but basically it just points out a couple things. That a bona fide, low cost, high impact rural health system, which we have developed, worked with the communities in 10 countries in very poor remote areas within those 10 countries, as you know, for $40 per capita, consisted mainly, to underline mainly the fact that you can't have health in a vacuum. So you see that it really should include focus on education, infrastructure, agriculture. It also has to have a referral system, but the basic components are community health workers, professional community health workers, paid, properly trained, properly supervised, and smartphone empowered community health workers. There should be a clinic, one for every 5,000 people, so that everybody has physical access. There should be no point of service cost, because even a very small entry fee deters people from coming, and a referral hospital with an ambulance, a functional ambulance. So what we have learned in the Millennium Villages is that you can, for a mere $40 per person per year, at this point it would probably be more, this is in 2004, but we kept that costing frame till now, you can have access to, that all the villagers can have access to decent health care, and then you can actually make an impact. This just puts it in another way, which is that the model primary health system that we built with the communities in the rural areas is to how to deliver the sort of the three main service packages: safe childbirth, nutrition, and then all of the infections that we discussed. That how do you deliver these through the different service channels? You know, how do you do it at outreach? How do you do it at the clinic, hospital? And what is the management, the infrastructure, equipment, drug supply, the supply chain, etc., that's required? And by the way, in terms of outcomes, as you know, because I think you probably are reading about it, the Millennium Villages Project has just been 10 years. It's been 10 years. So it's just now finished a thorough evaluation, all of the 10 sites. That's just finalized, and so the data will be looked at, and also there's an external component. So we'll see. I'm sure what it will show is that some places it did, some places it didn't. Even in a particular site, you know, that some things may have worked, other sector may not have worked. It's a very rich set of information, but overall it's been actually quite effective. So what is the primary health system? And it's the system component that I'd like to underline, is that you have to start with don't start with how much money USAID happens to give you and then look at what it is that you could do with that little bit of money. Start with knowing what your needs are. What is the needs? What is the burden of disease in your region? Start with the epidemiology, and then look at what the goal should be, and then do an assessment that way. So, but start with what you see on the ground and where you want to go. Then gather the core intervention packages, which are now well known, and then make sure that you have all of the necessary systems components, which are planning, budgeting. You know, you have to have the workforce supervision. You have to be working with the community, and therefore empower the community to know what it should be demanding and what it should be overseeing. And you need real-time data. That's another thing that we've worked in the Millennium Villages for the last almost 4 years, is real-time data. That's really been very interesting and very powerful. The fact that our community health workers carry a cell phone that both helps them at the household. It also tells the manager what the community health worker is or isn't doing. It also informs surveillance for resurgent diseases. If somebody, you know, if the manager sitting at the dashboard sees that all of a sudden there are many more cases of bloody diarrhea that week, they may actually look at what's happening in that community, and you may find out all of a sudden you have Ebola cases or whatever. And so you're right, you know, incredibly the first to notice that there is a problem before it's big. And the real-time data therefore allows adaptive implementation. Instead of just a year or two later when the surveys show you that there was a high child mortality, and then you start looking, what is it that happened that year? We now get it day by day. Why during that week 2 children died? Usually it's only 1 a month. Why? So it's adaptive implementation and management adaptation from the real-time data. So mHealth is a huge component of what we advocate for low-income systems. This just is the Millennium Village Information System, which, as you see, is fed by information from many sources because it's multi-sectoral, web-based, and it's mainly done, all of the one that say Form Hub and ComCare, all of them are done by smartphone. So there are no paper, and it's real-time information. And that way we use it to do an assessment of infrastructure. Does the clinic have electricity, water, equipment, agricultural business, monthly school reporting, both in terms of the infrastructure, but also this monthly school reporting actually did some literacy and numeracy tests. You probably had Radhika or somebody from the education system discuss that. Certainly in the health system, we had information from the clinics, from the households, and then of course there are the usual DHS demographic health surveys that are done every couple of years. But it's the real time and the compilation of all of this data that really allowed us to have a very intimate response to what was or wasn't happening in the community. So this brings us to my favorite mantra, which are these 17 goals. And I think the reason that the SDGs are so important is that it benefited from the process that I sort of described to you, which took us way too long, 70 years of dithering little bits here and there. And it really helped clarify that that's no longer the modus operandi. Number one, that we should have serious goals, and that therefore, a donor giving a small amount of money is, should make us question, how does that help? This is the goal. This is what you're giving us. How does that help? The health goals have also been informed by all of this experience. So these are the goal 3, which is goal 3 says ensure healthy lives. Now that already is a big difference. It's not talking about TB, malaria. It's talking about healthy life, much more holistic concept. Promoting well-being, even more holistic, and at all ages. So that it's not just focusing on children and women of reproductive age. So it's a much broader concept, number one. Number 2, the first 3 of the 9 SDG sub goals are related to, like the MDGs, they are maternal mortality, newborn children, and the main killers, HIV, TB, malaria. But then in this iteration, 15 years after the MDGs, there are non-communicable disease goals or sub-goals, which are these. And then the last 3, I think, are absolutely critical. I underline in 3.8, universal health coverage. As you remember, we've been talking about health for all, since middle of last century, but this actually mandates universal health coverage and financial protection right there in the goals. And that's hugely transformative. It makes it easier for those of us who are out there fighting for these things, because now it's not just some crazy whatever, it's actually a sub-goal that has been agreed upon as reachable, feasible, reasonable by all of the countries, 160 some that signed the SDGs. And so the 3 things that are critical is health, universal health coverage, taking into account financial risk protection, and that it should be health services, systems. So here are the 3 things that were missing in the MDGs that are now in the new construct. I just wanted to remind everybody what the definition that has been agreed upon for the universal health coverage, which is it's the the target is to achieve universal health coverage, which includes financial risk, preventing financial risk, and access to quality essential healthcare services. So it speaks to all people having access to essential services. It speaks to promotional things. There's a big emphasis on anti-tobacco work, preventive, of course, vaccine, a hugely life-saving for children, therapeutic. It also discusses actually palliative, end-of-life care. And the main emphasis is that one should not go bankrupt personally while seeking this. And then interestingly enough, also in distinction to the MDGs, they actually discuss a little bit of how, a little bit of means of implementation, which is critical. The MDGs did not address that, but that was the learning curve, one of the many lessons that we've learned from this protracted history. And finally, thank God, there is also a cry for increased number of health workers. So increasing the number and training, especially community health workers, is really life-saving. And I actually am involved in something called the CHW campaign, which is really riding high on this concept. It also discusses early warning risk reduction, and it calls for increased financing internationally. So basically, the SDG is great because the SDGs in health are great because it actually, unlike the MDGs, which just talked about intervention, this one talks about actually packages of services, number one. It discusses access. How do you deliver it to people? How do you make sure people come and get the services? And then it talks about cost. Completely transformative. Of course, people already are arguing about this and the other thing. There are all sorts of things that are problematic about it. One of the main things that's problematic but solvable is how do you track progress? As you all know, because I'm sure you do know much more about this than I do, but tracking the progress on an implementation process is critical. As they say, if you don't measure it, it's not happening. And so the reliability of data is always in question. And now we're not only asking to look at interventions and just indicators like deaths and births, which are quote unquote relatively easily measured. But now you're looking at how do you measure whether a system is functional and if the quality, even more subjective thing, is the quality adequate. And how do you measure that? How do you measure that impact? And then the critical thing is making sure that as you're measuring it, that you're disaggregating the data by socioeconomic and other, by minorities and by other subgroupings, because a country can look, that it has relatively decent, let's say, child mortality, but if there's a huge disparity, as there is, for instance, in the US, that's not good enough. So this has been a challenge on how to make sure that we track these more difficult to track items. And I don't know if you guys are aware, probably most of you are, but if you're not, there is already the first so-called first global monitoring report tracking the universal health coverage. It's online, called the First Global Monitoring Report. It's done by WHO and World Bank Group, and it's excellent. And it's already starting to discuss both the challenges of tracking progress, as well as how they are recommending that they be addressed. And just to give you one example, which was relatively new to me, how do you track the financial protection against financial ruin? How do you track that? And so in addition to the sort of obvious one of how much does a country's budget go to health, there are some others that they are going to be using. One is looking at prepaid services, looking at the pooling of risk, and then not only pooling of the risk, but then how do you measure that even out of the pool, the redistribution out of the pool is equitable. They're going to be measuring out-of-pocket expenditures, and apparently their threshold is it should be under 20% of the household income. Then they're going to be looking at catastrophic health expenditures, which are expenditures for health that are more than 25% of the household income. And then even a worse category, which is, okay, so this was a catastrophic expenditure, a huge chunk of the household, but did that chunk bring the household or that family down to poverty line, below the 1.25 that the World Bank calls poverty line? So they'll be measuring all of these parameters, which of course, again, have flaws in them. You obtain these by surveys, household surveys, which are flawed. it misses completely people who don't go to clinic at all. So you may go to a household, they'll tell you, nope, no out-of-pocket expenses. Nope, I didn't become impoverished. And that would make the household look okay, when in fact, they never, they were so poor that they don't even go to the health services. So even when you're looking at the financial way of evaluating the system, you have to combine both, of course, the indicators for cost, but also health indicators. So this is, in case you didn't hear me say, this is my ode to the SDGs. For me, you know, of course, it's only ground floor, base one, which is why, you know, many are not so excited. But it comes with a huge amount of infused lessons learned from partial successes, like Jim Grant's pioneering success, partial successes, many failures, lots of rhetoric, lots of scientific accumulation of scientific knowledge. And so this finally, I feel, puts us on a roadmap that we can actually all embrace, and actually have been embraced by all of the countries, which in and of itself is huge. How many other things have been consented upon by all of the countries? And it now has the right framework. So I love the fact that it's consented upon. So if you're a naysayer, fine, but 190 or whatever, 160 heads of state agreed on this. It's goals-based, so no more, you know, let's improve this, let's make a little bit of a better situation. It's you either, you know, we're aiming for these goals, period. It's a holistic approach. That's why there's so many more goals than MDGs. So it's not just health, not just education, but all of the others. It also, even within the sector, it talks about more of a holistic approach. So for instance, in health, it takes into account the life cycle. So it's not just TB, HIV, malaria, but it's what do you do to keep newborns, children, adolescent, mothers, old people that are important also. That's the non-communicable disease category, etc. And it supports the idea of a systems delivery. And that's critical, because that then opens up the possibility that we're exploring right now, for instance, ourselves at the Earth Institute, which is how do you take advantage of finally a funding mechanism called the Global Financing Facility, which just is going to open in 2 months, which is the first such financing facility that's open to taking proposals for healthcare delivery. Until now, you could apply to PEPFAR for HIV, to Global Fund for TB, malaria. There was no place to apply if you wanted to improve the actual infrastructure and the system that I described. You know, the community health workers, the nurses, the supply chain, etc. And the fact that the SDGs discuss systems allows that approach. And so we're working with a couple countries to get them poised to be the first at the door of the Global Financing Facility for community health workers specifically. It addresses finances, it hugely focuses on the metrics, and it gives international accountability. And because now we will have all a common metric, poor countries, rich countries. This speaks to poor and rich, so it's really embracing. And international accountability will come from that. And I just want to show you, it's not fair, but for me, I'm not being fair, but the first SDGs report came out, unfortunately only for the OECD countries, but since it's the first one, I wanted to show you. Of course, it puts the US in a very poor light, because these are the OECD countries, so it doesn't talk to middle income or low income countries at all, or some middle income. And the OECD average, looking at the healthy life expectancy, is 71. And as you see, the US is number 26 out of 34 countries. So for one of the richest countries in the world, we're nowhere near the top for life expectancy. And this brings it clearly with accepted metrics, agreed upon metrics clearly to view. Obesity, we're number 1 in the US. So we win on the obesity marker. And then the overall report card for the SDGs, shame on us. The US is number 29 out of 34. So not to beat up on the US, but just to show you that these metrics are really helpful when you're actually trying to make all sorts of comparisons. So you can, for instance, ask yourself the question, what is it that Japan has done right that their obesity is so low? So this really, allows, it's not just for invidious comparison, it's to allow us better understanding and therefore better approaches. So that's what I wanted to tell you, and I'm sorry that I took longer than I was supposed to. If there are any questions, I'm sorry.
Questions
Oh, right.
on the Hangout itself. And Columbus students also will come in with questions here, but then in the next half, then we'll have
But right now, focus on the
now it's
ones.
just here, and you do the select, and
So you just click select,
Select.
and then the question,
after you're done, then
you click done.
Okay.
Ah.
Should I read it or people see it, right? Well,
Read.
it's obvious that sub-Saharan Africa's health system is hugely financed by foreign aid, a mechanism that contradicts the meaning of sustainability. What can developing countries do to assume ownership of their health system? Absolutely terrific question, and completely apropos. So the idea of external aid is really just to help jumpstart some of the countries who absolutely cannot, out of their small total budget, do the total set of interventions. The countries that are at $300, $400 per capita, even if they do what they have been mandated to do, which is to put 15% of their budget to health, even that would not be able to actually cover the full cost. So what we're advocating for is that that the external donors partner with the governments to do it together. If the government doesn't put up any of its own investment, whether it be in cash or in kind, I too would be against foreign aid. But I can give you an example that I'm working on very acutely right now, which is Ghana. Ghana has decided just in June 11th, the president decided to have a national scale community health workers, unbelievably brave and bold. And so the situation is that if there were discussions with donors and others, if Ghana does a certain amount, so for instance, they've agreed that they will do the salaries, they will do the training, then and only then will the external donor bring some of the commodities and the logistical support. So the idea is that it's a partnership, and the domestic partner absolutely has to show, number one, that they're serious. Number two, that they're so serious that they're putting their money in it, albeit not the total package needed, and that they are serious about making plans on how they will scale up their portion at the expense of the external donor. The best example, I mean, this is the one that I'm actually involved in right now, but the best example actually, of course, is Gavi. Their business model is they take a country. If it's completely destitute, war-torn, they do pay 100% of what's needed for the immunization. But then if it's, let's say, Ghana or Nigeria, they prorate it. And they also ask the country that every year, so let's say if 1 year Nigeria is paying X percent and the donor is paying the remainder, the expectation absolutely is of a gradual change in the ratio. So you're absolutely right. If the government, and the expectation is that, as Gavi has noticed and experienced, there are countries who slowly over time can actually take more and more of the responsibility. So the idea is it's sort of like a scholarship for going to, for going to school. When I came here from Czechoslovakia when I was in high school, my parents had not a penny. So the choice was either I don't get educated or I go to schools that are not that good, or I get a little bit of a helping hand to go to college. And then I've paid that many times over out of gratitude, but it actually made the difference. But I think I'm sorry to be so personal, but I actually do feel personally about it, which is that there are situations, both people and countries, that there are times where people need help. And of course, I would only help those that show their own commitment. So Marlee Sander is absolutely right. The governments have to be part of the deal. It didn't go away. Maybe I didn't answer it properly. Oh, select. What if I don't want it? Oh, I did something. What if I don't want it, as in what if I don't know the answer? Lots of successful interventions involve community health workers. Oftentimes, these interventions, however, were highly contingent on foreign aid, capacity, training and funding. How can we assure sustainable transfer of knowledge and capacity to local government? So, excellent question, because it is actually, well, for me, it's sort of the crux of what I'm doing. I would, the sustainable aspect of it is that we work with countries who actually know what their needs are, know what they could be doing, but they also know what parts are not reachable. So for instance, Ghana, again, the president and the Ministry of Health said, we're able to do 3/4 of the system, but we really can't do the remainder. However, for the year after next, we will rebudget after we see how this works. So sustainability, by the way, is the key. So, none of us that I know are advocating for handouts. That's not the point. The point is to help catapult, over the inflection point so that the governments themselves can do it. So with the community health workers specifically, we're actually working in Ghana with the Ministry of Labor, because it turns out the Ministry of Labor has a big problem of facing a huge unemployment of young people. 50% of young adults who graduate from high school, and not everybody makes it to high school, but 50% of those that do end up unemployed. And so actually we're working with the Ministry of Health and Ministry of Labor, putting them together so that the budget that the Ministry of Labor has will be used for hiring the community health workers. So actually Ghana is doing a lot of its own heavy lifting, and there's just some technical advisory and a little bit of funding to support the process, which is absolutely expected to be shifting to more and more the government. Do you believe that expanding healthcare coverage will translate into patients receiving quality healthcare when many hospitals, even here in the US, are already functioning beyond capacity, limiting patient-provider interaction? That speaks to my past as a practicing medical doctor who tried to do her best in a setting where the setting, especially in tertiary care hospitals, but even in referral hospitals, was contrary to delivering quality care. In the US, it's pretty egregious where, for instance, I was tracked. The metric of my performance was not how many people I kept alive, and I did keep some alive, but the metric was how many patients did you see per hour? So as I was practicing, instead of my heart beating for, how do I make sure that this child really does survive this illness, the incentive that I was constantly being reminded of is, you're taking too much time with that patient, cut it. So, if the patient on the way out, after a clinical resolution, let's say of the problem, on the way out says, by the way, doctor, I wanted to tell you, we're getting divorced. I'm not sure what's going to happen to the 2-year-old. Do you grab them back in and take what is the most important thing that actually you just learned about this child's chances of doing well? Or do you say to yourself, I'm really sorry, good luck. So I actually think that this is an extremely good question, and that again speaks to why I and Jeff and others on our team are focusing on community health workers, because I think community health workers actually are not only an absolute advantage, are hugely important in a setting where you don't have enough nurses and doctors. I actually think that they're useful even in our setting, because most of the problems that people deal with are relatively a narrow category of things. And so just like the MDGs address the major killers, so too the main problems that households and families have, can be really grouped into 15 or 20 things, and therefore you can actually train somebody to address those problems and to recognize when they can't address the problems, when they should refer up. So we're advocating for a huge expansion of community health workers, because not only is it needed because there aren't other personnel, but because actually they're better at it at the household level. They're better at certain things than the other more technically higher educated personnel. So as some of you may know, our former colleague, Dr. Prabjot Singh, started community health workers in our backyard. It's called CHW, but it doesn't stand for community health workers. It stands for City Health Works. And they've taken this concept right in East Harlem, where actually when people are discharged from Mount Sinai Hospital for a certain category of illnesses, diabetes, hypertension, obesity, they get coaches assigned to them who keep these people from, who help the people get the food that they are supposed to eat, make sure that they get the medication. They sustain them, and they've noticed, and so have insurance companies that are now funding them have noticed, that it hugely impacts on rehospitalization rate. So there are actually things that are better taken care of by community health workers, not just in places where there aren't the other cadres. Even in places where we have plenty of the other cadres, there really is a role for coaches or community health workers. And I think the question is absolutely correctly formulated.
You guys are all awake today. Most of the questions are from this group.
Oh! Wow. How can you, oh, you know people. And here I thought I was answering somebody in Beijing. With recent trade agreements and stricter intellectual property rights, many medications remain too expensive for people in poor countries. What is being done to keep costs low and ensure the availability of generic medications around the world? So this is where I have to plagiarize and tell you what I learned from my in-house economist, which is that, in fact, this absolutely being the case, that there are medications that are completely out of reach, the costs are completely out of reach for the poor people, that there should be many things, but one of them is segmented markets, that there should be an ability, and it has been done, of course, for HIV and others. There should be a different price for the markets in low-income setting, where the company should be asked to either give it at cost. We're not asking them to be philanthropists, so they don't have to give it for free, give it at cost, or at least have it subsidized by other international organizations. So segmented market is one. And then, of course, the other thing is when you're talking about US drugs, they're hugely, hugely overpriced because of the problems that Jeff has taken on the hepatitis C drug, which is a lifesaver, completely curative for a horrendous infection, and it's been marked up many orders of magnitude. And so there are solutions, market solutions, with subsidies and with asking for at cost for certain markets, and it absolutely has to continue. Oh, where do I go? Oh, Madagascar. I've been there, love the country. Oh, but don't ask me to say hello, Miss Rakotondramanana. As the developing countries are poor, they do not have means to invest a lot in health, though people are vulnerable from many diseases. How can we solve this situation? Being a pediatrician or a public health practitioner, I think the health is the sine qua non of development, and therefore it needs to be the starting point of investment for the country. So because health is so important, that should be a higher priority for the budgets and for the governments. It's obvious that if you have a sick child who's not getting attended to, if they survive, then they're going to be either less productive and or worse, they'll be less productive and a burden on the system. If you don't have family planning, and also if you're a woman who doesn't have access to family planning, and if you already have the experience that 1 out of 5 of your children will die, obviously that woman is more likely to have many more children as a way to make sure that some of them survive. And without any social safety net, having children is the only safety net. Then what these high fertility rates of the women do, what it does is it makes them not, they themselves are basically pregnant, lactating, and child rearing, and therefore are not able to be productive members in the society and economically productive. So health is a huge underpinning. And so my answer to you would be, Kanto, that health has to be prioritized. Should I take another one, or?
Yeah, and then 3 down again, or 4. There's one in Dublin.
Dublin?
Yes, right there.
Climate change appears to be a major challenge in the achievement of healthy and equal lives. What do you think the most important step forward would be to overcome this challenge? One of the reasons that I'm so grateful for the SDGs is that it hugely focuses on climate change. And by the way, I'm sure many of you know, but that was not a done deal from the beginning. There were many who were fighting at the UN, although the process was a very good consultative process and very transparent. But in the very beginning, climate change was not to be included. But there were many who absolutely put their lives down to make sure that it's included. So luckily, it is included. And therefore, this kind of question really is paramount, which is, how do you address both climate change and the health consequences that come from it? And I actually do see the health consequences from climate change visibly many times a year when I go to the project sites and countries in the Sahel, or especially in the drylands. For instance, we have one that Glenn established in northeast Kenya, Millennium Village of Durtu, which is a nomadic population which lives with its livestock grazing. And the droughts and the desertification that you all know about has really made the life that was already on the edge for this population dramatically more difficult. And so we see children dying more of things because of not having access to clean water, therefore sanitation. And also, of course, the desertification decreases the amount of food that the animals can eat, and therefore consumption for the family is decreased. So it increases malnutrition, it increases the water stress, increases problems with sanitation and hygiene, so children die of diarrhea. It is a hugely stressful situation. And then the other, of course, thing that climate change in areas where it increases dryness, what it does is it makes people turn against each other, because if you have children that you're responsible for, you are willing and able to do anything and everything to get to the water point, even if it happens to be across the farm of your neighborhood farmer. So that, by the way, droughts, and we also went to another Millennium Village that our colleague Amadou Niang started in North Ghana, in the Savannah Accelerated Development Authority area, which Ghanaians call overseas, even though it's nowhere near the ocean. It's way up high north, very much inland. They call it overseas because when it rains, it is completely cut off from the rest of the country, and little areas are cut off from each other. And it's actually difficult to survive. We actually were there this summer. We went, Jeff and I and a couple other people, and we actually could not, we saw parts of it, and we actually could not make it to the other part because the Jeep, although it was well constructed, they said would not make it through what used to be a road and will be again a road in a month or two, but right now was a lake. So these incredible sharp huge quantities of water that come all at the same time, all at once, are incredibly destructive. And therefore, by the way, we saw a clinic. We actually saw a clinic across this. I have a picture of it across this vast. The people were waiting for us. They knew we were coming, and we actually did not meet. We saw each other, but there was just no way. So climate change and health is obviously very directly linked, which is why I'm glad that they're intercommunicating via the SDGs, or at least the invitation there is to intercommunicate. By the way, we do have a colleague named Madeline Thompson, who's going to Malawi tomorrow, who is studying very concretely how individual specific, for instance, studying now how the El Nino that is about to really impact hugely, how does that specifically impact on meningitis and other diseases. So it's a very critical question and an important area to be involved in if you're interested. Okay. Since my answers are starting to all look alike. The top one?
Yes.
One of the challenges in most developing countries is that professionals are not equivalent with the population growth. What strategy are needed to reduce professionals' patient level in this rapidly growing population? So that's a two-part question, a very relevant one, which is that most low-income countries do not have sufficient number of healthcare professionals. And not only because they don't educate enough, but as you will hear, anywhere where you go to in sub-Saharan Africa, for instance, I frequently go to medical schools and nursing schools just to for conversations with the professionals and students, and they will tell you half of them graduate and leave because a nursing degree or a medical degree is a global commodity, and so they leave. So the unfair part of all of this insufficient number of health professionals is that we here in rich countries benefit from the brain drain. And actually, there's the governments in sub-Saharan Africa and India are subsidizing it because the professionals come here with the education that was paid for by the government. I don't blame the people who brain drain, but it's a fact of life. So there is both an absolute and a relative, again, insufficiency. And by the way, that is one of the reasons why we're so focusing on community health workers, because it's been shown over and over again how impactful they can be. They really can improve child survival, but they don't brain drain out because they really are only relevant and able to function in not only in their country, but actually in their community. And that's what makes them so helpful. So there has to be an increased number of professionals, but that won't happen until they're in their remuneration package and their satisfaction with delivering proper health care, for which they don't have the tools of the trade, makes it so that the health professionals want to stay. So a lot has to happen to have many more nurses and doctors. The ratio of nurses and doctors to population is unbelievably skewed in low-income setting, not enough by any means. And then, of course, the demand, as you correctly point out, Grace, the demand side is also a problem, which is that the population is growing at a rate that's not sustainable, both in terms of for the family. If you have more than 3 or 4 children, if you're very, very poor, it's really hard to guarantee that child's nutritional intake, education, even affection. And so it's not good for the family itself. And then as a country, of course, keeping up with the population, if you're a country that actually is in poverty, is really very difficult. So both things have to happen. The ability to produce and keep the professionals is important, and the ability to assure women that their children will survive is the best incentive for the women to use family planning. Believe it or not, or you believe it, that most places it's not just the access to family planning, it's the access to the security of knowing that your children will survive that will actually make the parents choose and be willing to use family planning methods. So child survival, ironically, because of course many uninformed people here say, you know, why are you trying to help people in poor countries have their children survive when there's too many of them anyway? It is, it's as close to being able and willing to kill somebody that I come when they say that, because it's of course exactly the opposite. It's the poverty that drives the increased number of children that the women have. Thank you.
Thank you. So with this, we have, sorry folks out there, we have to close our global classroom session now. Thank you again, Dr. Sachs, for a really eloquent and passionate kind of basically telling us the basis for how the basis for kind of stages for health is so critically important. It is the system-wide focus on health that's needed. It's not just on the clinical or even on kind of the public health, but it's just the system-wide approach, and which has ramifications for the other SDGs, and in turn has lays the foundation for development. And through the example that you gave, not just in parts of Africa where there's a lot of focus traditionally in the MDGs, but increasingly how SDGs need to be really considered for the industrialized countries as well. So thank you again very much. And what we'll now do is, with the end of the global classroom, at least for the Columbia folks, we'll keep up these questions here so that when you come back from coffee, we'll give Dr. Sachs a chance to kind of go over and answer the questions here. So thank you again. Okay, and goodbye. Good night.